So let's talk about this modern topic, shared decision making. What is it and how can we do it? These are my disclosures. So ultimately, a decision has to be made. So there are two decisions that I will cover in this talk. Should a man get screened for prostate cancer? And the second is, should a patient with low-risk prostate cancer go on active surveillance? Do you have these conversations in your clinic? Do you find them easy, hard? No? So this talk is going to be novel, a little provocative, some food for thought, and hopefully when you leave this room, I will have equipped you with some tools that you can bring with you to your clinic to ease these conversations, both for you and for the patient. Let's start with screening. So usually it looks something like this. A patient has gone through his laundry list of questions, and then at the end he holds his hand on the door handle and says, "Oh, so what about the PSA test, doc?" And then what do you do? What do you say? How can you have this conversation in a few minutes? And first of all, which guideline should you follow? As you know, there are multiple guidelines. This is not a complete list. But no matter which one of these you follow, they all have in common that you should focus on shared decision making. So this is now the US PSTF 2018. It's now a C recommendation, where the man should have the opportunity to discuss the benefits and harms of screening and incorporate his values and preferences in the decision. The AUA also strongly recommends shared decision making, and the NCCN guideline, which we will talk about, also emphasizes this risk and benefit discussion. So how do we do this shared decision making? Do you start by saying, well, this is very controversial, and then what do you say? Well, first of all, what is shared decision making? Where does this come from? It takes two to tango. So it is the pinnacle of patient-centered care, care that is respectful of and responsive to patients' preferences, needs, and values, and takes into account that and guides that in all clinical decisions. It requires that both parties share information, so as clinicians, we can share the options and we describe the benefits and risks, and the patient then expresses his or her preferences and values. So it's really a shared information. Where does this come from? How did we get here? Does anyone know the background? Why is this so popular? Why do we talk about this? So it goes back into the history from the 1970s, where medical ethicists started to talk about patient autonomy, and there was this critique of paternalism or just trust the doctor. In 1982, the Presidential Commission explicated shared decision-making for the first time. And then there was this author publishing a book about the silent world of the doctor and patient, and in recent years, we have a plethora of information. Patients now come into our offices with printouts from the internet and they want to discuss. So they are more and more informed, so we need to be at the forefront here. There's also this atlas that the Dartmouth Institutes have published since the early 90s, showing that the care you get depends on where you live. This is the small area variation in procedure rates for preference-sensitive surgery. So this is an example of breast-sparing surgery in the US. And we see something similar for prostatectomy rates, where we see an 8-fold variation in prostatectomy rates between hospital referral regions. So this suggests that we are not using shared decision-making as we should. And the first question we have to ask us, is the decision preference sensitive at all? Well, I mean, if the hip is broken, we need to fix it. Or if we have an appendicitis, we take it out, right? But a preference sensitive decision is when there is more than one reasonable way or path forward, including the option of doing nothing. And these different paths entail various combinations of benefits and risks. And this is the case with PSA screening, because once we've drawn that blood, we might open the door to potential downstream consequences. These consequences can be many. As you said, you've all experienced the man who comes in with urosepsis after biopsy, anxiety waiting for the PSA test, surgery, radiation, complications, impotence, incontinence, all sorts of downstream consequences from just one blood draw. But how do we have these conversations? Should we talk about all these consequences, give numbers? What should we do? We did this interesting study where we interviewed key opinion leaders in the field. And basically what we found is that there were two schools of thought, one that focuses on preferences and one that focuses on behavior. And I'll explain to you shortly in a minute. We also reviewed a lot of sort of decision aids that are out there, usually information sheets or online material for how it's recommended that we have these conversations about shared decision making. We found that current recommendations either specified too little to allow patients to make a decision. It's like this little boy, oh sure, I'll take this one, or yes, I'll get the PSA test. Or so much that it overwhelms people's ability to choose rationally. Here's an example of too little information, one decision aid that says, treatment can lead to urinary, bowel, sexual, or other problems that might be significant or minimal, permanent or temporary. I really don't know how this information helps me decide. Here's an example of a decision aid that has too much information, where it's recommended that clinicians inform patients on 16 points and ask 12 questions about preferences. I don't see how that's clinically feasible to do. And it's interesting, we know from consumer research, I know all of you have probably felt this when you're at the supermarket and you're choosing which jam to purchase. If you're given 6 choices, it's more easy to choose than when you're given 30. And it's the same with information. More options, more information and autonomy can actually cause cognitive overload and negative affect. Other problems with these decision aids is that we use data and terms that might be difficult for patients to understand and assign a value to. Here's a decision aid that talks about the risk of deep vein thrombosis or pulmonary embolism. I don't know if patients know what these terms are. The estimates that they cite might also be conflicting or questionable. Here's one that says 30 more men will be treated for prostate cancer for every 1,000 men screened. Another aid says 110. I mean, which of these numbers are right? I've also seen a lot of inaccurate information in these decision aids. One of them said, it is currently not possible to predict which men are likely to benefit from treatment. I mean, it's as if there is this unknown potential of the opponent, but that's not true. I mean, we have the Gleason score. We know perfectly well which tumors are aggressive and which ones are not. Another one said, a man who's willing to be screened might be willing to be treated without definite expectation of benefit. And that's not true either, because there is this whole concept of active surveillance. So there's a lot of misinformation out there and a lot of information in these decision aids. So as doctors, we understand the anatomy of the human body. This is Pat Walsh's description of the neurovascular bundles. We know exactly what to do at the time of RP. And I think it's time that we also start to understand the anatomy of the human psyche if we are to do the shared decision-making right. And what I found when I reviewed all this literature is that the traditional approaches or the current recommendations of shared decision-making is basically throw numbers at people. Throw words, numbers, and pictures at people. And what's very popular is this sort of infographics, or where you show patients for every 1,000 men screened, you will have 240 with a positive result, 100 of those get a biopsy, and so on and so forth. And the thought behind this is that this minimizes cognitive bias. And when you review the literature of randomized trials where they've tested decision aids versus usual care, you show that people feel better informed, they're more knowledgeable about their options, they're more clear about their values, and they're better prepared for decision making. But the problem with this approach is the problem with numeracy and literacy. We basically have too much quantitative information, and all of these numbers are also incommensurable. It's like, imagine going to the flea market and you have $100. What do you get? Well, you get 2 chairs, 1 bottle of wine. It's like, how do you synthesize all this information? 1,000 men screened, 240 positive tests, 50 men get impotent. I mean, I cannot synthesize all of this information in my head into one discrete choice. So this is what I believe is the reason why the implementation of shared decision-making and decision aids in clinical practice has been limited. They're not used as intended at the point of care. They're too complex, and clinicians don't have the time to have these conversations. Most of them are written at too high literacy level. The average person reads at a 7th to 8th grade, but most of these are written at a 9th grade reading level. So this is problematic. And also, highly educated people have difficulties understanding simple numeracy questions. This is an example of a study where 400 men and women over the age of 40 with more than high school education were asked which of the following numbers represents the bigger risk. Is it 1 in 100, 1 in 1,000, 1 in 10, 1%, 10%, 5%? 1 in 5 gave an incorrect answer. So if this is true for highly numerate people, I mean, it's not impossible that the same holds true for less numerate people. And yet the current approach to shared decision making is throw numbers at people. And I also wonder, is there any other routine screening test other than PSA testing where we have these type of complex discussions? We don't have these discussions before we draw the blood for measuring cholesterol or blood pressure. We don't warn patients about all the possible downside consequences. But this is what the recommendation is for PSA testing. And when you think about it, most men will have a normal PSA. This is the PSA distribution among men age 60, and you can see that over nearly 75% of men will have a PSA less than 2. So that means that we have these lengthy shared decision-making communications and discussions with patients in whom the downside consequences might never apply. We also know that a PSA test has a reassurance value for the majority of men who are screened. So that means if you have a normal PSA, that's a good thing. You might not even have worry them, but they might be reassured. So instead of focusing on all these old school principles of doing shared decision makings, our take on this as a modern approach to decision-making is to focus on the bottom line gist. And this has been written by Daniel Kahneman and others in this book, for instance, The Dual Process Theory, about how humans process information. And people can encode trade-offs and benefits and harms, but we decide based on gist. So the bottom line, sort of underlying gut feeling, how we feel about a decision. And people tend to make more informed decisions when the presentation format requires little cognitive effort. So in an attempt to do so, we try to develop a decision aid for PSA screening that focuses on this gist. And in this case, we believe that this is, can I live with untreated cancer? And that is because the most important problem with PSA testing is the risk of overdiagnosis. So my colleague Andrew Vickers at Memorial and other colleagues developed a simple schema for informed decision-making about prostate cancer screening. And it's simply a small schema with 10 simple talking points. You can find it online. Some primary care physicians have printed this out. They laminated it, have it as a pocket card to help have these conversations in a simple, time-efficient way. Because this is what shared decision-making would look like in the ideal world. Here, Dr. Pinto, he has plenty of time to discuss with the patient pros and cons, but this is usually what it looks like in the real world. You have a few more minutes and you have a full waiting room. So what are these 10 simple points that you can discuss? You can find these online. Number 1, most men will develop prostate cancer if they live long enough. We know that from autopsy studies, you all know that. Number 2, only a small proportion of men with prostate cancer die from the disease. Everyone also knows that. We also know from randomized trials that screening reduces the risk of death from prostate cancer. We've also seen that in the US after the introduction of the PSA test, that the mortality has dropped by almost 50%. But as I said, the problem is that many low-risk or indolent cancers are detected that do not need treatment, and there were a lot of them in the European trial and also here in the US. But the problem has been that most of these cancers have ended up getting treatment. Over the past 2 decades or so, the rate of active surveillance was only 10%, and it's only in recent years that we have seen an increase. And the problem is prostate cancer is associated with the risk of problems with treatment, incontinence, erectile dysfunction, and bowel problems. And most cancers found by screening are these low risks that do not need treatment but can be safely managed by careful monitoring. And we have multiple cohorts now documenting the safety of active surveillance. So therefore, if you choose to be screened, there's a good chance that you will be diagnosed with a low-risk cancer. And if you have a low-risk cancer, your doctors or your family might pressure you to treat it. So therefore, Number 10, here's where we try to facilitate the discrete choice. A screening candidate is someone who is confident that you would only accept treatment for an aggressive cancer and would not be worried about a diagnosis of low-risk disease. Whereas someone who's not a screening candidate is someone who would be uncomfortable knowing that they have cancer and not treating it. So these are the 10 simple talking points that ends up with a discrete choice at the end, instead of having a long and complex decision aids that throws numbers at people. So this is our suggested approach to PSA, how to have shared decision-making conversations for PSA testing. This is the first reaction usually, or often from men, do I need to cut it out now, doc? And here's an approach to have a conversation about treatment. You have all these different treatment options, and it's almost like you are a waiter and you provide a menu. Here's the menu, now you choose. Is there a way that we can do shared decision-making more responsibly? And like the gentleman in here in the front said, there's really a small subset of individuals for whom there's equipoise, where we can actually have these discussions about active surveillance versus radiation versus surgery. Because in most other forms of prostate cancer, we know what to do. If it's a low risk, usually the option is active surveillance. If it's high risk, if it's metastatic, we have all these treatment options. But it's really the high volume, low risk disease or the low intermediate risks where this really comes in. And increased use of active surveillance is really essential to reduce the burden of overtreatment, and we now have more and more long-term data that helps mitigate the concerns regarding safety. And actually 80% of urologists and radiation oncologists believe that active surveillance is underutilized, and 71% state that patients are not interested in active surveillance. And why is that? Well, a lot of patients say that they seek to get rid of or cure the cancer. I don't want to leave it alone because it might spread. I want to get it out of me if I can. These are sort of sentences that come up in qualitative interviews with patients. Men also perceive active surveillance as doing nothing. If you watch and do nothing, it's going to obviously progress. It's like while you're waiting for the time bomb to explode. This is a common perception. And few men are aware that immediate treatment might not improve their survival. Here's the man who says, if you want to live, you might just have to make decisions to do things to extend your life if you can. But if you want to give up, you can give it up or just wait and see. And this is not always true. Some men feel unspoken pressure from their family to choose aggressive treatment. My wife keeps asking me why I haven't chosen a treatment yet. And this is also very common. What are the solutions to this? How can we increase active surveillance for men whom we think it might be indicated? Well, genomic tests are possible solutions. That could be a talk in and of itself. There's also a cost associated with these tests. Another solution is multidisciplinary clinics, which can help increase adherence of active surveillance to about 60%. Another way to tackle this problem is nomenclature. The qualitative studies affirm that Gleason grading is a significant source of confusion. It's a mystery to everyone. It's totally confusing, says patients. And 84% of men in this interview that Dr. Loeb did showed that men said it would be much clearer if the Gleason score was on a scale from 1 to 5 instead of 6 to 10. Here's a patient who says, my background is business, not real estate, not medicine, so there's a lot of jargon. And remembering what the Gleason score is, and all of this that I remember is that it exists and my number is bad. So de-stigmatizing low-risk prostate cancer by changing the nomenclature is one way forward, and that's one of the rationales behind the new grading system. So instead of the Gleason score, we now have the grade groups 1 through 5, as you are all familiar with. Another very interesting aspect is communication. It's not what you say, but learning how to effectively say it. So my colleague Befar Edey at Memorial Sloan Kettering collaborated with Deepak Malhotra, who's a professor at Harvard Business School in Boston. And Professor Malhotra came to Dr. Edey's clinic, and he sat with him, and he watched him have these conversations with men. And they together developed a systematic approach to discussing active surveillance that uses framing techniques from social psychology and behavioral economics. And this was featured recently in the Wall Street Journal. And the patient here in the journal, he describes, my conversations with my doctor never felt like a negotiation. My mindset was cut it out, get it out, cut it out. But my doctor said I would be happy to do your surgery, but I wouldn't advise it. And this man went on to active surveillance. And if you want to read more about this approach, you can find this online, and Befar has published supplementary material and where he describes exactly what he said in these conversations. And interestingly enough, when Befar taught my colleagues at MSK this approach to counseling men, the rate of active surveillance went up from 69% to 81% after the intervention. So there's really power in our words. What are some of the principles that Dr. Day and colleagues used? Well, one principle is shifting the conversations from positions, that is, what you want to do to treat your cancer, from surgery, radiation versus active surveillance, which is often perceived as a life-death decision, to interests, just like we talked about with the BPA treatments. What are the patient's interests? So ask the patient to discuss what the diagnosis means to him and his family and unmask the underlying interests in the decision. Another important behavioral economics principle is resetting the default. So instead of talking about active surveillance as a third option, you should describe active surveillance as the first option to boost the appropriateness. Another principle is leveraging social proof. So people do what other people do, they follow the crowd. So do not describe active surveillance as something that's rarely chosen, but instead you can say, if it's at Memorial, 80% of men like you choose active surveillance. And you can also say that all the guidelines suggest that men like you be managed with active surveillance. Another principle is loss aversion. So this again is from Kahneman and Tversky's prospect theory that losses loom larger than gains, and people are more motivated to avoid perceived losses than pursue perceived gains. So if you talk about the complications and the risks with surgery and radiations, people have a tendency to want to avoid those complications. Another principle is that of anchoring or reference points. So usually when we talk about active surveillance, we talk about checking the PSA ever so often and so on and so forth. But if you start with an anchoring by saying, Mr. Jones, we believe that the PSA test has enabled us to find your cancer about 5 years earlier, and therefore changes to your tumor are not expected until the second decade after diagnosis. We could safely see you again in 5 years, but we will monitor you closely and check your PSA every so often and repeat the biopsy every so often, what you do at your institution. So that way patients don't feel like we're doing nothing, but we're safely monitoring them more frequently than we actually would have to. Another very important principle, or a powerful principle, is that of establishing credibility. And trust increases when you recommend an option that is opposite or contrary to your own perceived bias. So if you're a surgeon or a radiation oncologist, you can say, I'm a surgeon, I love to operate, or I'm a radiation oncologist, I can radiate your prostate. And I believe that that could be beneficial in many cases, but I do not think there is a benefit to surgery or radiation in your case, and I would recommend active surveillance. Remember the man in the Wall Street Journal, this was a very powerful word. And then there's the role of education. If you present patients with data, easy to understand figures that demonstrates the long-term safety, and you emphasize again that it's not doing nothing. You can also preview the experience to know what you can expect. Future anxiety, most men like you will feel anxiety at some point, it's normal. We have resources to help. Possible resistance from the family, are you comfortable discussing this? What are some questions? So that you sort of have talked about the things that might come up so that the patients do not derail from the decision. And then a member of the physician's team should follow up via, for example, a phone call soon after the visit to address any additional doubts that might have arisen. And now you might say, okay, this is all great, but it's going to take time, it's going to increase the consultation time, but in our study we found no evidence that it actually increased the consultation time. So this is very interesting, novel ways of thinking about shared decision making and using principles from behavioral economics. So in summary, thank you. I think our role as clinicians, when there is more than one path forward, is to help patients choose the path forward that matters most to them. Thank you.